acute complications of diabetes, and one of the most important and most commonly seen acute complications of diabetes is diabetic ketoacidosis. So let's today discuss together the pathophysiology, the clinical presentation, and later on how to manage, how to treat a case presenting with diabetic ketoacidosis. And before going into details of diabetic ketoacidosis or DKA, let's define first what is DKA. What does DKA mean? And away from the sophisticated definitions in textbooks, simply DKA means a triad of D means diabetic, blood glucose usually is more than 250 milligrams per deciliter. K means there is ketosis, there is ketone bodies, whether in the serum or the urine. Acidosis means the pH is less than 7.3. So in the simplest definitions, practice-wise, DKA is a triad of D, diabetic, hyperglycemia, with blood glucose is more than 250 milligrams per deciliter. K means there is ketosis. And when I'm saying ketosis, this includes ketonemia, means increased ketone bodies in the blood, and ketonuria means excretion of ketone bodies in the urine. And we're going to this point, which to believe in more, the serum ketones or the urine ketones right now. And A means there is acidosis, means there is pH less than 7.3. When you find the three components of hyperglycemia, ketones, and acidosis, this is called DKA or diabetic ketoacidosis. Pathogenesis of diabetic acidosis, DKA, which is very important to understand the therapeutic interventions that we're going to do in patients with DKA. DKA simply starts with insulin deficiency, and here is the name of the game. Insulin deficiency can be absolute insulin deficiency or relative insulin deficiency. Absolute insulin deficiency means that, for example, a patient with type 1 diabetes, and we know that in a patient with type 1 diabetes, the patient is having absolute insulin deficiency. And the patient stopped insulin therapy. So the patient will be having absolute insulin deficiency. Or a patient presenting with type 1 diabetes. At presentation, many patients with type 1 diabetes do present with DKA. This is called absolute insulin deficiency. But insulin deficiency can be relative insulin deficiency. What do we mean by relative insulin deficiency? And we usually see relative insulin deficiency in type 2 diabetes. The patient is already having insulin, but due to medical stress or surgical stress, for example, the patient is having major surgery or having acute medical condition like stroke or acute coronary syndrome. In these stresses, there is the release of counter-regulatory hormones, catecholamines and cortisol. And when these counter-regulatory hormones, which are the enemies of insulin, are in excess, the insulin is relatively deficient in this case. So insulin deficiency, whether it's absolute, for example, type 1 diabetes without insulin therapy, or relative insulin deficiency, for example, a patient with diabetes with some kind of stress and the release of counter-regulatory hormones, the deficiency of insulin will lead to decrease the glucose uptake by the peripheral tissues. We all know that insulin is responsible for entry of glucose inside the cells. So when there is insulin deficiency, the glucose uptake will be decreased. And this will lead to hyperglycemia. When the blood glucose exceeds the renal thresholds, glucosuria will occur. And osmotic diuresis will occur, leading to urinary water losses. When there is excess loss of water, this can lead to dehydration. But it's not only water. Associating loss of water in diuresis, there is loss of electrolytes as well. So there will be electrolyte depletion, especially potassium. And the patient will get total body depletion of potassium in DKA. So there is on one side, deficiency of insulin will lead to hyperglycemia. When the blood glucose exceeds the renal thresholds, osmotic diuresis will occur. This will lead to water loss, ending up with dehydration together with electrolytes depletion. On the other hand, insulin, we all know that insulin is anabolic hormone, which usually inhibits lipolysis. So insulin deficiency will lead to, yes, increased lipolysis, increased lipolysis, degradation of lipids, degradation of triglycerides. And as we know from biochemistry basics, triglycerides molecule is nothing but glycerol with free fatty acids. So when there is lipolysis, the triglycerides will be degraded into the components of the triglycerides, glycerol and the free fatty acids. Glycerol will pass through gluconeogenesis in the liver, and this will lead to formation of glucose, adding more to the hyperglycemia. And the free fatty acids in the liver as well will go through ketogenesis or beta oxidation, leading to generation of ketones. Ketones like beta hydroxybutyric acid, acetoacetic acids, and acetone. And I'm saying acid twice. So excess of ketone bodies will lead to metabolic acidosis. So again, insulin deficiency will lead to increased lipolysis. This will increase the level of glycerol and the free fatty acids. Excess of glycerol in the liver through a process of gluconeogenesis will lead to formation of glucose, adding to the hyperglycemia. And the excess of free fatty acids in the liver through ketogenesis or beta oxidation will form excess of ketones. Ketone bodies are just acids, so excess of ketones will lead to metabolic acidosis. So we started here by insulin deficiency, and we ended up with the triad of DKA: hyperglycemia, ketosis, and the metabolic acidosis. Not to forget dehydration and electrolyte depletion, the two hallmarks of DKA. This is the pathogenesis of DKA. And we need to remember it very well to understand the lines of treatment of diabetic ketoacidosis right now. Well, we need to remember together a couple of definitions which we're going to need in the treatment of diabetic ketoacidosis. Number one, what is anion gap? Anion gap equals the serum sodium level minus the sum of chlorides and bicarbonates. So again, when you hear in the treatment that, well, we have here wide anion gap, we need to care about the anion gap. What is anion gap? It equals sodium minus the sum of chlorides and bicarb. The normal anion gap is from 7 to 9. And when anion gap is more than 10, this is pathological. This is called wide or high anion gap. Another definition we need to remember is called corrected sodium. In case of marked hyperglycemia, we use in the treatment the corrected sodium level. What does it mean? Corrected sodium equals measured sodium reported by lab plus 1.6 for each 100 milligram blood glucose more than 100. What does it mean? Well, if the patient is presenting with blood glucose, for example, of 500 milligram per deciliter, and the lab is reporting that the sodium level is, say, 130. In the treatment, you do not work on the measured sodium, but you need to calculate the corrected sodium level. So how to calculate the corrected sodium level? Well, if the measured sodium is 130, for example, and the blood glucose is 500, so when the blood glucose is 500, we have 400 above the serum level or the blood glucose level of 100. So you calculate 4 times 1.6. This will give 6.4. So add 6.4 to measured sodium, which is 130. So the sodium level, the corrected sodium level, will be 136.4. يبقى ببساطة شديدة لو المعمل قال لك الصوديوم بتاع العيان ده 130، حضرتك ما تشتغلش على 130. قول أنا هحسب الكوركتد صوديوم اللي هي الميجرد صوديوم، أجمع عليه 1.6 لكل 100 ملي بلاد جلوكوز فوق ال100. يعني لو السكر 500 في كام 100 فوق ال100؟ 4. اضرب 4 في 1.6 هيديك 6.4. يبقى اجمع على 130 6.4 هيبقوا 136.4. هو ده الرقم اللي هشتغل عليه. دول 2 definitions عايزكم تفتكروهم كويس في علاج الدي كي اي: anion gap and corrected sodium. So what are the diagnostic criteria of diabetic ketoacidosis? We have just mentioned that DKA is a triad of D, K, and A. Well, some more details. Diabetic, so blood glucose by definition in DKA should be more than 250 milligram per deciliter. K, so there is positive ketonemia and or ketonuria. It's better to rely on serum ketones, yet it's not available in many labs and it's not available in our everyday practice. So we go to the urinary strips and measure ketonuria, but definitely measuring blood ketones is more accurate than measuring urinary ketones, and we are going to touch on this right now. So there is acidosis, metabolic acidosis. So the pH is less than 7.3, acidosis. Metabolic acidosis by carb is less than 18. And the type of metabolic acidosis here is metabolic acidosis with high anion gap. Means that anion gap is more than 10. So these are the diagnostic criteria of DKA as per the ADA. After diagnosing DKA, we need to decide about the severity of DKA. Is the patient we are having is just mild DKA, or moderate DKA, or severe DKA? The importance of this classification, this should decide where would you manage the patient. If it's mild DKA, the patients can be managed in emergency departments, in the emergency room, in the ward. But if the patient is having moderate or severe DKA, the patient should be admitted to ICU. Comparing the mild to moderate to severe DKA, you can see very well that it's not at all about how high is the blood glucose. It's not at all about how heavy is the ketones in the serum or the urine. But it's all about the degree of acidosis. So in mild DKA, the pH is ranging from 7.2 to 7.3, and the picarb in the range of 15 to 18 milliequivalent per liter. In moderate DKA, the pH is ranging from 7 to 7.2, and the bicarb in the range from 10 to 15. Severe DKA means the pH is less than 7 and the bicarb is less than 10. So the severity of DKA depends on the degree of acidosis rather than the degree of hyperglycemia or how much of ketones do we have. So simply, if the bicarb is in the range from 15 to 18, this is mild DKA. If the bicarb is the range of 10 to 15, this is moderate. The bicarb is less than 10, this is severe DKA. Anion gap in mild DKA is just above 10, but when the anion gap exceeds 12, we are talking about moderate or severe DKA. And lastly, the degree of acidosis reflects on the degree of consciousness. A patient with mild DKA, you will see the patient pretty alert. A patient with moderate DKA is usually drowsy. A patient with severe DKA, usually the patient is comatose. So after diagnosing DKA, you decide about the severity, and according to the severity, you decide where would you admit your patient. A patient with mild DKA can be safely managed in the ward, in the emergency department, but if the patient is having pH 7 to 7.2 or less than 7, a bicarb is less than 15, the patient should be managed at intensive care unit setting. Well, What is the differential diagnosis of diabetic ketoacidosis? The most important is hyperosmolar hyperglycemic state, or HHS. And we used to name it hyperosmolar non-ketotic coma, but this name has changed because simply we have been using the term hyperglycemic hyperosmolar non-ketotic coma, but you can not say coma for every patient, because if the patient is having early hyperosmolar hyperglycemic state, the patient is still conscious, and you cannot put a diagnosis that, well, this patient is having non-ketotic coma and the patient is conscious still. So it's called the state rather than coma. The next point, you do not see here the term non-ketotic, because many patients with hyperosmolar hyperglycemic state are having some degree of ketosis. So you cannot say non-ketotic and the patient is still having some ketosis. Hyperosmolar hyperglycemic state, how it's different from DKA. The hyperosmolar hyperglycemic state is more common in type 2, whereas DKA is more common in type 1 diabetes. The blood glucose here is much higher. It's usually exceeding 600 milligrams per deciliter. In DKA, it's just more than 250. Here, there is no acidosis. The pH is more than 7.3. In DKA, it is less. The bicarb here is more than 18. In DKA, by definition, the bicarb is less than 18. There is no acidosis here. And the hallmark of hyperosmolar hyperglycemic state is high serum osmolality, exceeding 320. But take care. In the urine, you can have some minimal ketosis, ketone bodies, mild or slight ketonuria, or there is no ketones. That's why you do not say it's no more. We do not say now non-ketotic coma, because you can find here some ketone bodies in the urine. So the hyperosmolar hyperglycemic state is more in type 2 with very high blood glucose, but there is no acidosis, because the patient with type 2 is having some residual insulin that can prevent acidosis, that can prevent significant ketosis, but this insulin level is not enough to prevent such a marked hyperglycemia. No or minimal ketosis, but the hallmark here is marked increase in osmolality. This is the first differential diagnosis of DKA. What else in the differential diagnosis? Other causes of ketoacidosis. Not every patient with ketoacidosis is having diabetic ketoacidosis. Other causes include starvation ketosis and alcoholic ketoacidosis. So whenever you have a patient is presenting with ketosis, please ask about history of alcoholism, and please check if your patients have been starving in the last 24 hours. This can explain many patients with ketosis. And lastly, we mentioned that DKA is one of the causes of high or wide anion gap metabolic acidosis. Is it pathognomonic for DKA to find a patient with high anion gap metabolic acidosis? No. Other causes of wide anion gap metabolic acidosis include lactic acidosis, salicylate toxicity or methanol toxicity, and renal failure. These causes are associated with high anion gap metabolic acidosis as well. Lactic acidosis, it's actually very rare to see in your daily practice, but it carries a very bad prognosis if there. Salicylate toxicity, we usually see a patient with aspirin toxicity can be a suicidal attempt. Aspirin toxicity is associated with metabolic acidosis with wide anion gap, severe gastritis, but the prognosis of aspirin toxicity is very good. Methanol toxicity can sometimes be seen, and the patient is presenting again with wide anion gap metabolic acidosis, but optic nerve damage can be a hallmark in methyl alcohol toxicity. Renal failure or uremia, we commonly see renal failure, and it is one of the causes of metabolic acidosis with high wide anion gap as well. These are the differential diagnoses of DKA. Hyperosmolar hyperglycemic state, other causes of ketoacidosis, starvation and alcoholic, other causes of high anion gap metabolic acidosis like lactic acidosis, uremia, and drug-induced metabolic acidosis, for example, aspirin toxicity and methyl alcohol toxicity. Lastly, not every case presenting with DKA and you're going to see in your practice is a straightforward case. I mean, you will find many cases presenting with atypical presentation. Let's see some of the examples. We mentioned that typically DKA, the patient is presenting with a triad of hyperglycemia, ketosis, and metabolic acidosis, right? These are the triads diagnosing diabetic ketoacidosis. And the question here, can any of these three components be missing in a patient with diabetic ketoacidosis? Let's start with hyperglycemia. Can a patient presenting with diabetic ketoacidosis without hyperglycemia? And the answer is yes. And this is called euglycemic DKA. Mean the patient is presenting with ketosis, with metabolic acidosis, but the blood glucose is less than 250. Euglycemic DKA. What can be the cause? This can be due to exogenous insulin injection before going to hospital, and or food restriction. For example, if the patient is type 1 diabetes, is finding that the blood glucose is very high, the patients can take extra amount of insulin, and again extra amount of insulin. This extra amount of insulin can eliminate hyperglycemia when the patient is at hospital, but ketogenesis and acidosis are still there. Another explanation, if the patient is having progressive or persistent vomiting due to diabetic ketoacidosis, there will be food restriction. So if the patient is presenting to you after 2 or 3 days with persistent vomiting, the patients can be having low blood glucose, but the metabolic acidosis is still there. Another example of euglycemic DKA is some reports that the use of SGLT2 inhibitors can be associated with euglycemic DKA. The exact mechanism is not clear yet, but at the end of the day, many patients, if the patient is not well chosen, if the patient is, for example, dehydrated, not well hydrated, with start of SGLT2 inhibitor, the patients can get euglycemic DKA. Here the blood glucose will not be high, but the patient is having typically wide anion gap metabolic acidosis and ketosis. So this is the first possibility. Can DKA presents without hyperglycemia? And the answer is yes. This is called euglycemic DKA. Let's ask another question. Can DKA presents without evidence of ketones? Can DKA presents without having evidence of ketone bodies? And the answer is yes. Because simply we usually depend on the urine strips to document the presence of ketone bodies. Urinary strips usually used a method called nitroprusside reaction. And this method does not recognize beta-hydroxybutyric acid, which is the main keto acid in DKA and the earliest ketone body to be released in DKA. This means a patient's early in the course of DKA and you are doing the urinary strips for the patients, the urine strips does not see the beta-hydroxybutyric acid. The urine strips detect acetone. And in early stages of DKA, with still significant release of beta-hydroxybutyric acid, urinary strips can give negative results. And the message here, that it's possible for a patient to have DKA when the urine shows negative for ketones. So clinical suspicion of DKA is important. If your patient is presenting with metabolic acidosis with high anion gap and marked hyperglycemia, if you find negative urine dipstick for ketone, please, this does not exclude that the patient is having DKA. Either you request for him serum beta-hydroxybutyric acid if the facility is available, or you do follow-up of the patient after 2 hours, after 4 hours, after 6 hours in the urine, you will find that the strips will give positive results later on in the course of DKA. So the question, can DKA patients present without evidence of ketone bodies? And the answer is yes, if you are using the urine strips and the urine strips is giving negative results for ketone bodies, this does not exclude that the patient is having high serum level of beta-hydroxybutyric acid, which is the main and the earliest released ketone body in DKA. So DKA can present without hyperglycemia, can present without urinary ketone bodies. And the question, can DKA presents without evidence of metabolic acidosis? It seems to be a difficult question or a weird question. How is DKA without A? without acidosis. But actually, the answer is yes. Sometimes DKA presents without evidence of metabolic acidosis. And to explain, let's see the story of this patient. This patient is having type 1 diabetes, giving history of gastroenteritis with severe vomiting since 5 days. And because she is not able to eat, she stopped insulin. She is presenting with dizziness and she seems very unwell. And on examination, she is dehydrated. So again, she's having a type 1, and she reported progressive and persistent vomiting since 5 days. And because she cannot eat, she stopped insulin. She is presenting with dizziness and dehydration. These are the lab data of this patient. Blood glucose is 418, but the pH is fine. The bicarb is fine. There is no evidence of metabolic acidosis. Sodium is 128. Potassium is 3.5, 3.5. Her chloride is 76. And the question is, could this lady have DKA with this data? And the answer actually is yes. And what happened here, despite normal pH and normal bicarb, she is having excessive vomiting for 5 days. And this can lead to metabolic alkalosis, which can neutralize and mask the metabolic acidosis of diabetic ketoacidosis. And the clue here is when you calculate the anion gap. Anion gap for this patient, the sodium is 128 minus the sum of bicarb and chloride, 24 plus 76. Anion gap is 28. Anion gap is much, much, much higher than normal. It's more than 10. So the patient here is having diabetic ketoacidosis, but the metabolic alkalosis is masking the metabolic acidosis typically, which is a very difficult patient to diagnose actually. But the answer here, yes, some patients, it's not common, but it occurs, it happens, with DKA present with without evidence of metabolic acidosis if there is associated metabolic alkalosis. And typically the patient here is not having significant metabolic acidosis. Well, these are the exceptions. These are the exceptions. But let me end up to remind myself and to remind you that typically DKA is having the 3 components: hyperglycemia, ketosis, and acidosis by having D, K, and A. So the patient is having DKA, and these are the typical diagnostic criteria of DKA: blood glucose more than 250, pH more than 7.3, bicarb less than 18. There is evidence of ketone bodies, and there is high anion gap with AG more than 10. This is the typical presentation. Yet, please remember that some atypical cases may be there, and you might face in your practice, so you need to be ready for that. Thank you very much. This was about the pathophysiology and the clinical presentations of diabetic ketoacidosis, we will see later in the next lecture, the management of DKA. How to treat a patient with DKA will be next lecture. Thank you very much for your kind attention.